So objectives, lots of stuff. So let's start with the case again. 30-year-old female, minor fall from stairs, diagnosed with midfoot sprain. Okay. Anybody thinks this X-ray is normal? Or anybody thinks let's put hands up? Who thinks there's something happening in this X-ray? Okay, only one hand here thinks that that's an abnormal X-ray. Good. Rest everybody thinks it's normal, right? Two, slowly hands going up, there as well. Somebody's awake there in the middle. Good. Good morning. There, right in the end. Somebody is awake. Thank you. Okay. So hopefully after this talk, which may be a long talk depending on how the interaction goes, I presume none of you guys will miss a list frank. The reason is, not in India but in the Western population, list frank is one of the most common cause of litigation in EMS or emergency department and by general practitioners. Okay, and I'll tell you why. So seen by another physician, diagnosed as fracture of base 5th metatarsal, treated in a plaster for 6 weeks. Finally, she turned up 3 months post-injury to me. Her daughter and my son study in the same school. She finally landed up with me. So, doc, something's wrong. And she literally came crying. She is like a small girl, baby. 3 months already in plaster. Now she is with the deformity, with the assumption that she will be probably another 3 months in plaster. Like 6 months in plaster. Guess, has anybody had a plaster in their foot anytime? Nobody. It's miserable. Okay, because you can't do a lot of things, especially work. So there you can clearly see big deformity happening in the midfoot area. So it's not true. Does this work? No. Big deformity, hindfoot valgus going up as well. You can clearly see on the both sides. And this was 3 months post-injury. And you can clearly see the first fracture, the base of the second metatarsal is not lined up with the medial border of the middle cuneiform. Okay. There's a big gap present. Now you can clearly see it, but this should have been picked up day one. So question to ponder, why were list frank injuries missed? Why are they so important? And once a patient is sitting in a clinic at 3 months' time, what do you want to do then? So, 20 to 40% of patients with list frank are not treated in timely manner. Either they are overlooked or they are misdiagnosed as foot sprains or isolated fractures of the tarsals and metatarsals. They are overlooked in multiple trauma patients. And usually it's because of the lack of training, awareness, or in our country, patients not seeking medical attention in a timely manner. But once they are done, they should be treated properly. Now, why should you know about this? Because list frank joints, if not treated appropriately in a timely manner, can cause chronic pain, functional loss, deformity, especially a flat foot deformity and secondary arthritis. A brief on the anatomy. There are 4 units which I mentioned. The first unit is the first TMT, which has few degrees. It's a 6-degree movement still present, which is important. The second and the third TMTs are fixed. There is hardly any movement, and the mobile fragment is the 4th and the 5th. Okay, list frank ligament is important, goes from C1 to M2. There are 3 parts to it. The biggest is the interosseous, which is the strongest, and the plantar as well. Okay, that's how it looks on the MRI scan. And I think nowadays more and more people who are reading the MRI scans, even your radiologist, if you talk to them, they can tell you what is happening with the list frank ligament. Sprains, I'll just talk to you briefly on sprains. Grade 1, 2 and 3. Very mild sprain is grade 1, minimal swelling, minimal pain. And usually the joint is stable. Mild swelling, mild pain, instability, mild laxity is there but no instability. And grade 3, significant swelling, significant pain. and there is a disruption of the first TM of the second of the Lisfranc joint. So what you want to do is you want to identify these type of grade 3 sprains because you don't want to miss them, so you can treat them appropriately. Examination. There is in my book there is nothing like midfoot sprain. I have to prove that the patient does not have a Lisfranc subluxation or a displacement for me to then treat the patient conservatively. So, high index of suspicion, midfoot, any patient coming with midfoot pain and swelling or patients with polytrauma has to be examined and proven that they do not have Lisfranc. Check for the vascular status, assess the soft tissues around the whole foot and the ankle. Swelling a large lump in the midfoot area as shown here. They are unable to weight bear, tenderness along the TMD joint and tenderness along the passive midfoot pronation. So you just don't ask them to move their ankle and move their toes. Literally you have to hold the metatarsal heads, stabilize the ankle and then turn it. If you turn it, if you rotate around the midfoot area and the patient complains of pain, I think it is usually Lisfranc. Always look on the plantar side of these patients. If you have a bleeding or ecchymosis in the middle part of the foot, it's again a pathognomic sign of Lisfranc injury. Okay, the piano key side. So tenderness along the base of the second metatarsal, or you hold the metatarsal head and move the metatarsal head up and down, and the patient complains of pain in the midfoot. That's called as a piano key side. X-ray evaluation, AP, 30 degree oblique and lateral views. These are the lines, especially people who are graduate or coming up for the exams, or even people who in practice should know these lines. So the medial border of the, the lateral border of the first metatarsal to the lateral border of the medial cuneiform. Medial border of the second metatarsal to the medial border of the intermediate cuneiform. Then you have the medial and lateral borders of the lateral cuneiforms lined with the medial and lateral borders of the third metatarsal. These have to be absolutely in line. I mean, there's no question about it. You can take whichever view you want. You can take an AP or an oblique view. That has to be there. Okay, there's another medial border of the cuboid in line with the medial border of the fourth metatarsal. And also, I don't know if you have it, you have like how you have in the ankle a coin sign. Here also you have a coin or a dime sign on the base of the fifth. Not big coin, but a small coin. This is another one called as a notch sign, which denotes a medial cuneiform rotation happening, especially if you have an intermediate cuneiform instability. May or may not present with a CM-M2 widening. Now, on a lateral view, why you should have a lateral view? Because you want to see if the dorsal subluxation is there or not on a lateral view. Now, all these X-rays are not for this. This is a no-brainer. Everybody can pick it up. It's only for those subtle Lisfranc which you want those X-rays to be done. So, standing X-rays provide a stress and demonstrate the subtle diastasis which you want to see.
Need to see in our practice if it is whether it is significant or not. So it's a talk basically made for everyone. He is a 16-year-old boy. He came to my OPD with a flat foot posture, and he said, "Doctor, I have a bad foot pain on the medial aspect of the foot, somewhere here, which is where the arrow is made, while playing the sports only." He's a 20-year-old boy, so first 6 to 7 slides is about what the patient says to us and whether it is significant or not. Another case, 20-year-old boy, he said, "I have, doctor, pain around whole of my heel and there are a lot of stiffness. Although it knocks not very flat, but the heel is in valgus, the medial part is prominent, there is loss of longitudinal arch, and he has pain all around the heel and the stiffness." She is a 50-year-old. She came to me and she said, "Sir, I have a pain on my inner side of the heel of the hind foot." So first two were children's, adolescents. Now she is a 50-year-old housewife. She has a flat foot posture with loss of arch and hind foot in valgus. 45-year-old active lady, teacher by profession. She said, "Sir, I have severe pain on the outer side of my foot and the knee as well." So basically she has located a finger over the peroneal tendon and she said, sir, I have a pain over here and I have a knee pain also. Another 42-year-old female, she has the complaint of the pain on the outer side of the foot as well as she has some bony prominences. So she has some palpable bony prominences on the outer side of the foot. So this is what the patients say to us. So purpose of showing these slides is what the patients of flat foot deformity, they tell from various locations, medial side, lateral side, stiffness, flexible. So these all things we need to understand. There is a 35-year-old male, he came to me and he said, I have a very severe nocturnal pain and severe calf pain and as well as a constant knee pain, and he had a severe flat foot deformity as well. So why do we need to treat the flat foot? The logic is very simple, because if the pillars of the body, they are not in the neutral position, they affect the proximal joints as well. It may lead to hyperpronation of the heel, it may lead to the internal rotation of the tibia, internal rotation at the hip, kyphotic correction at the level of compensation at the level of spine, and it may lead to the pain not only in the foot but to the other part of the body as well. So in short, it disturbs the lower limb alignment and may leads to the proximal joint pain. So look at a simple case here. He is a flat foot, so on putting a weight, while putting the whole weight in the gymming activity, he gets some internal rotation of the tibia on weight bearing. And there are many studies which say that the flat foot morphology has been associated with the early OA and in the older adults. So we treat a coxa vara because it's not acceptable, and we treat the genuvarum deformity sometimes because it's not acceptable, malaligned. But why don't we treat the hindfoot valgus? So we need to understand and put some efforts to find whether they are painful or not and they are significant or not. So sometimes they may complain with the medial talar pain because of the pathologies either in the tibialis posterior or in the talonavicular capsule or the other structures on the medial side like a spring ligament. So just for the sake of convenience, I have made the slide that in normally this is a spring ligament which supports the head of the talus, but if it is not working and if it is stretched out, it allows the medial talar deviation, plantar talar deviation, and leads to heel valgus as a compensatory deformity. So this is what we see. Sometimes the flat foot patients, they are more prone for the plantar fasciitis. They may complain of the heel pain. Bunion deformities, 20 to 25% of the individuals, they may have the flat foot deformity associated, and they may present with the early OA of the knee if it is significantly valgoid. So let's go to the case 1 and understand the importance of treating the flat foot deformity. So the case 1 which I showed first is a 16-year-old boy having a severe flat foot deformity and a pain on the inner side of the foot. He has been given all conservative treatment, medial arch support, calf stretching, tibialis posterior strengthening, everything, but he was not responding. So he has been posted for the flat foot correction. There are various methods to treat the flat foot deformity, but one of the common is in the adolescent is lateral column lengthening, medial sliding calcaneal osteotomy, Cotton's osteotomy, and a spring ligament repair. So this is how the pre-operative and the post-operative correction it looks like. And the child is doing good after 3 to 4 months of the surgery. Second patient, I have the pain all around my heel as well as stiffness. While evaluating these cases, we found that there is a big coalition. And the coalition syndrome, they are very painful if it is symptomatic. If they are symptomatic, the pain doesn't resolve with the conservative line of treatment most of the time. And here you can see that there is already subtalar arthritis because he is a 20-year-old with a big talocalcaneal coalition, calcaneofibular impingement, and a osteochondral defect. So he has been treated with double joint fusion with the subtalar and the talonavicular joint, and this is how he got the arch back and is doing good. The 50-year-old housewife, the third case, she has the pain on the inner side of the foot. What was the pathology? She has a tibialis posterior tendon dysfunction with a spring ligament tear. Look at the tear which supports the head of the talus, and it was completely thinned out, There was no support on the talar head, and that's why she is dropping the talus plantarly and the medially. And with the medial sliding calcaneostomy, tendon transfer, spring ligament repair, she has been treated and she's doing good. Case number 4, she had a pain on the outer side of the foot as well as the knee. Look at the heel valgus, the Charlesman view, which Dr. Pradeep sir has nicely mentioned. And she has been treated because she already presented to me in the subtalar arthritis, which is called type 3 flat foot deformity. So she has been treated with the flat foot deformity, good arch reconstruction, and this is a pre-operative and the post-operative visible changes, and she is doing extremely great. So for another case, you guys have any questions, you are free to ask. Thank you.
So open for discussion.
Yeah, Srinivas sir, please. Yes sir.
I had inquired because they know, I know them, and they had some air cast, something like that. After that, I had a communication with 2 of the patients. How they are feeling, means we are okay, they said. Is conservative treatment is okay in degenerated ruptures. Is it, I thought surgery is the main mode of treatment for that.
Yeah. So one of the indication of doing surgery for the chronic Achilles rupture in the older age group, which you say is 66 years, is gait disturbance. Because usually they don't have a pain after the rupture, but they have a difficulty in plantar flexion, they have a difficulty in going upstairs and the downstairs. So these are so physiologically younger age, these are the cases where you need to transfer the FHL tendon and you need to treat them. Otherwise, a majority of the patient in this age group, if their physiological level of walking is less, you can consult them.
And one of the patients, what he said is, this is okay, ankle is okay, but my knee pain got worsened after that.
So if you have no working Achilles, if your calf is not
10 to 15 kilometers, they are developing knee pain. In the daily walk of life, they are not having any problem, but during the runs, they are facing problems. We have corrected them using this Essex shoes and all, but in spite of that, they are getting knee pain while running. So, how do we address this?
So usually if you've gone to A6, you would have done a scanogram there.
Yeah, they are doing that.
Now this is again a fallacy. A6 really knows how to sell shoes.
Yeah.
Anybody wears A6? Only one person. Average cost of an A6 is more than 10,000. Average. Okay? And the first thing when you go to A6, somebody will just take the machine, they'll make you stand, they'll make you walk, and then make you run. Now, invariably, irrespective of your high arch, irrespective of your normal arch, flat foot of course, when you run, your foot will pronate.
Yeah.
It is meant to fall a little bit, that's a normal foot mechanics. So you see everybody, every time the salesperson will, you're pronating, you're hyperpronating, and he will sell you the most expensive shoe.
The numbers. Yeah.
Exactly. So that is the first part of it. So you look at your friend, see at 10, 12 kilometers what is happening in his running. Check what is where is he? Is he getting tired or is he getting a tibialis posterior tenosynovitis? Get an ultrasound or a good MRI done.
They are not getting the pain there, sir.
The knee pain.
They are getting the knee pain.
So knee pain, that may also be the IT band tightness.
They are getting it at the meniscus.
So then it is just that malalignment in the knee or just a very early start of that. Probably getting a steroid shot injection is best would be including. Or an shock wave therapy I think for that.
Thank you so much.
Okay.
Now we have a next.
Practical. This degenerated tendo-Achilles rupture, most surgeons just carry about the wound rather than the technique of tendon, but the wound problems, what measures we have to take for the wound healing, that is a big problem.
So the wound healing on the posterior skin is usually not a problem. Yeah. So as far as the dermatomal vascular supply of the foot is concerned, it is a lateral part of the foot which is more prone for the wound complications and not the posterior, number one. Second, the principles in foot and ankle incisions you have to follow everywhere. So you need a thick incision, thick flap, no touch technique, less retraction, no use of the tooth forceps. As you can, if you remember my the surgery, I have not used a tooth forceps throughout the time. So no cautery use, less tourniquet time, and a gentle retraction. So these are all the keys that you have to follow. You need to follow in all foot and ankle surgeries. Yes, sir. Alice you can use for the tendon holding you can use the Alice. Yes.
Last question.
Skin and the superficial dissection has to be very gentle. No net.
So FDL and the FHL they both connected at the level of the midfoot on the plantar side. They both are connected, and if you take out the tendon proximal to that connection, usually the toe flexion and everything will be taken care by the knot of Henry and the associated tendons. So there are a lot of studies which says no problem, no comorbidities. But if you take a long tendon harvest, if you take out the tendon from the tip of the toe, from the plantar side of the great toe, to get a big thick tendon, then it definitely affects the the toe flexion, and it could be the source of morbidity. But again, the gait studies they said it also doesn't lead to that much clinical morbidity.
Only in high-end professional athletes, your push-off strength is affected. For menials like you and me, probably it should be okay.
Okay, well, now we can start the osteotomy.
So it's so three things which we have already spoken. The three things which we have already spoken, we will try to cover it in the sawbone model. So first is how to take. There was 2-3 queries that from where to take out the Haglund deformity and where to keep a saw. What amount of the bone we need to remove. So as I said that you need to keep the patient in the prone position. So this is the Haglund deformity which is palpable. Sometimes that Haglund deformity is very palpable, and you can trace the Haglund deformity up to the tendon attachment. So while holding the saw, when you are cutting the bone, always use a mini saw as far as it is possible. Take the two retractors. So two retractors, the spikes which are holding medial and the lateral structures, and then you have to. So this is the medial and the lateral retractors, spikes. So you can see whole of the Haglund deformity medially as well as laterally. Now the position of the saw is always oblique. See here, the position of the saw is oblique. It is 30-degree oblique, so it should not hamper the subtalar joint. So even if you are taking the big Haglund deformity, it should not reach up to the subtalar joint. So this is how you need to move the saw and take out the Haglund deformity medially as well as laterally. Take out all the sharp spurs visible on the X-ray or the MRI. So you have to remove the bone till you get a good vascular bone. So the Haglund is always a sclerotic bone. So you need more pressure, more saw pressure to take out the bone. So this is how you need to remove the Haglund. So as you can see that the position of the saw was oblique, it should not go in parallel to the posterior process of the talus. So that is the thing. That is the thing we need to remember while cutting the Haglund deformity. The another thing which we need to demonstrate here is how to do the medial sliding calcaneal osteotomy, which is a very important part of the flat foot correction. So you have to keep the patient in the lateral position, identify the peroneal tendon. Yeah, so identify the tip of the fibula, identify the base of the heel bone, and usually this is the space like midway between the tip of the fibula and the Achilles tendon. So this is the midway where you need to start the medial sliding calcaneal osteotomy. Okay, so put 2K wires, and your osteotomy should be anterior to the Achilles attachment. So if you are taking an oblique osteotomy, you have to be at least 2 cm anterior, 2 cm anterior to the Achilles tendon attachment. Now in the medial sliding calcaneal osteotomy, you have to go completely in the medial aspect of the bone so that it should be easily sliding. So take a big bump midway between the fibula and the Achilles tendon. So this is a way of holding the mini saw.
You don't go on the medial cortex. Okay, so medial cortex is always left. So the saw will just come on the bump in the saw, just touch the medial cortex, and then you complete the osteotomy with a osteotome. So then what you do is, one thing, just a technical tip, you will put your towel or something here, keep this loose, take a broad osteotome and just hammer it. When you hammer it down, it will become loose, and then you can push it down. And your bump will just help it push it medially. Okay? Here we don't have an osteotome, so we just
So there's another thing like how much amount of the bone you have to slide it medially. So it is usually 1 to 1.5 centimeter of the.
easy to do it. So what you could do is put a laminar spreader, put it on this, open it up, so it becomes loose, and to just loosen it up. Gradually it will take time, and you almost shift it that much, and you can measure it. You can see from here approximately that much, 1 to 1.5. 1.5 is too much, I think. I think 8 millimeter to 10 millimeters is what I normally get an average. 6 millimeters here, that should be good enough. And then you have to pass your screw from the medial tuberosity, from the lateral tuberosity center and then into the calcaneum. Okay? So that's the shift. Any questions on that?
The lateral wall exostosis. So now how to take out the lateral wall exostosis, which Dr. Pradeep has already mentioned in few cases, that there was a big bump which was impinging the peroneal tendons. So you have to keep the position, again patient in the lateral position, take a lateral extensile approach, identify the lump, identify the axial exostosis and put.
So the best thing to do is, it's quite easy. So what you have to do is you have to do a lateral extensile approach. If you are just doing a subtalar fusion, then a sinus tarsi approach is appropriate. But if in doubt, go for an extensor lateral. Now I know people are afraid of the extensor lateral, but usually in cold cases where the skin is usually normal or virgin, I think the rate of complications are very, very low. Okay? As long as proper tissue handling is done. The key is expose the lateral malleolus, and anything on that level, below that, you can put your osteotome. That is your level where you should be, your lateral wall should be. Anything above that bump, you just take it off. Okay? You can take it off with a saw, you can take it off with an osteotome. If you are going for an osteotome, you get one chance. So take slightly more than less. Okay?
Just understand the position of the saw, as Dr. Pradeep sir has said that you have to be at the level of the tip of the fibula. Okay, so don't go more medially and don't go very laterally, just it has to be like this. So this is the way of detaching the lateral wall exostosis at the level of fibula.
So here you take it and whatever comes. So here we don't have much, I'm just showing for the sake of it, but that's how you would do it. Usually with lateral, any calcaneum fracture, you will always have some kind of bump. So you can mark that. So that's why you need enough space here. So that's why an extensor lateral approach is a better option.
Last is medial malleolar osteotomy. Yeah. So for the talus fracture, we all are doing the medial malleolar osteotomy dual approach. So here the last osteotomy session is how to do the medial malleolar osteotomy. Again, there are 3 levels, but usually what we follow is at the level of shoulder. So how to take the osteotome and so this is the thing which you need to mark. Where is the shoulder of the medial malleus of the ankle joint, and keep the saw oblique 30-40 degree oblique, and just 1 centimeter above the level of shoulder you can have the level marked with the K-wire. See the Siam image. Don't go very proximal, otherwise you may cut more of the medial malleus this bony structure, and it may lead to more cartilage damage. But it should not be very less. Don't cut from this level. Don't go below the level of shoulder. At the level of shoulder or 1 centimeter above in the oblique plane. So this is a way of doing a medial malleolar osteotomy for the talar fracture.
Before you do that, make sure you put your artery right into that shoulder. So just protects your talar body as well as your cartilage. Okay? So like that you can just put it and then put an osteotomy.
So oblique osteotomy just above the level of shoulder, and it should be the complete osteotomy, because if you use the osteotome in the last, you may injure the cartilage. And pre-drilling with 4 mm guide wire CC screw is always helpful, so that after the osteotomy the closure will be easy. Make sure it contains all the structure of the deltoid ligament. So it should be the big piece and not a smaller piece. So this is the level of osteotomy, and you need to put the 2 screws, very common traditional screws which we always put, and pre-drilling with K-wires which I said, and in the closure make sure the deltoid they are not in the tension. 2 CC screws are usually sufficient. Thank you.
Any questions?
Thank you, sir. Thank you very much. Now I request our chair, please be.
Maheshwar sir, Mahinda Reddy sir.
And to begin with, we'll start with the pathological fractures. A pathological fracture is something that can be seen in any bone neoplasm. It could be in primary bone neoplasm, which could be either benign or malignant, and it could be also in a metastatic lesion in the bones. And the management, the way we approach the treatment of these particular tumors will depend entirely upon what the presentation is, what the site of affection is, location in the bone, what's the primary if we are talking about metastatic lesion, and what is the prognosis of the patient. So we will be covering every point one by one as we go ahead in the talk. So as soon as we get a pathological fracture in any of the neoplastic conditions of the bone, either benign or malignant or metastatic, the first thing that needs to come to our mind is what's the primary, what's the diagnosis, how are we going to work up these particular lesions, what could be the differentials, what is the prognosis, how is the patient, what's the age, what are the expectations, and what's going to be the overall outcome of this particular patient as we are treating them. And everything is going to be different in different scenarios. So let's see how we need to proceed. First and foremost, do not rush to treat a pathological fracture or do not rush to operate on a pathological fracture. Pathological fracture is not so needs to be approached that way. So we need to have a proper diagnosis, a proper pre-operative evaluation, and a staging of this particular patient. What happens if we don't do so? Now let's see this 50-year-old gentleman who presented to a peripheral center with a history of road traffic accident, and he presented with a fracture like this in the subtrochanteric area. If you look very carefully, there is some periostal reaction, there is some new bone formation in the soft tissues. They got an MRI done which showed an extraosseous soft tissue extension. They thought that this was a high velocity road traffic accident, and the surgeon decided to go ahead and do multiple elastic nailing for this particular type of a fracture. Unfortunately, the neoplastic etiology was missed in the proximal femur, and eventually the patient went on to have a very large lytic destructive lesion in the proximal femur and a very large mass and an unsalvageable situation, and the patient had to be treated with an external hemipteryectomy, that is an hindquarter amputation. So had this been picked up early, there was probably a better way of managing this particular case, which turned out actually to be a high-grade osteosarcoma.
Rodent sarcoma.
It's, yeah, kind of a rodent sarcoma, that's right, sir. Yeah, you know, I mean, all our Gujarati friends have made this particular terminology very famous, a rodent sarcoma, yeah. First and foremost, if you get a patient presenting to you with a bony lesion and a patient has a history of some primary neoplasm treated earlier, say for example a CA breast or a CA thyroid or a renal cell carcinoma, don't assume that any bony neoplasm that is seen in this particular patient in the patient's follow-up period is a metastatic lesion. Tuberculosis is one common presentation which is commonly seen in our patients. We need to have a biopsy from that particular bony lesion just to rule out whether it's infective or neoplastic or some other primary as well. So typically the way we approach this is a multidisciplinary approach where we have our multidisciplinary team sitting together. We have our radiologists, our pathologists, our radiation and medical oncology colleagues sitting together. Also our plastic surgeons, vascular surgeons and palliative care specialists sitting together in the MDT and discussing the best management for these particular patients. The commonest benign pathology that presents to an orthopedic surgeon with a pathological fracture is a unicameral bone cyst. And typically these are the easiest ones to manage because the treatment more or less, in the beginning at least, is conservative, and most of these particular pathological fractures will heal as the fracture heals and the cyst also heal. About 40 to 50% of them, the cyst may not heal, for which further treatment modalities may be considered. But a fracture per se definitely heals in these particular patients. So that's not something that we need to worry about. Most common benign bony tumor that we get to see is the giant cell tumor or an aneurysmal bone cyst. And these patients, about 10% of them, can also present with a pathological fracture as a result of a trauma to that particular affected bone. It does not mean that these patients are not amenable to an intralesional curettage. If we evaluate them carefully and decide to follow appropriate technique, it is possible to save their adjoining joints by doing a curettage and doing a reconstruction. Because most of these patients are going to be young patients, and it's very important for them to have their joint salvaged instead of being resected. Giant cell tumor with a pathological fracture also does not mean that it is more aggressive. It can be treated the same way as we treat a non-fractured giant cell tumor. So that was a case of a distal female GCT, which was treated in a conventional manner, extended curettage, reconstruction using a sandwich type of reconstruction methodology, bone graft in the subfrontal area and a bone cement, along with internal fixation. And you can see that a few years down the line, the patient's fracture has also consolidated and the lesion has also healed well and done well without any local recurrence. There can be some pathological fractures in giant cell tumors which are not salvageable. And this is decided by the proximity to the joint. The area that is fractured in this particular young gentleman, it was a neck femur and with a very large soft tissue component of the tumor. And in these particular cases, we can't really salvage the joint and we have to go ahead, do a complete resection and reconstruction in form of some sort of a megaprosthesis. So that was what was done for this particular patient. Fibrous dysplasias are another type of benign bony neoplasms which will present to us with pathological fractures. And that earlier concept of putting in cement and putting in long straight bone grafts or cancellous iliacrous bone grafts is now gone. We know that these particular lesions respond pretty well to oral alendronic therapy. And typically nowadays we treat them by using a simple, straightforward intramedullary fixation because we need to split the entire bone. And once the fracture heals, then cover them with oral biphosphonates. And these particular patients tend to do extremely well because we know that FDs have very high chance of local recurrence even if you try to do any cementing or any bone grafting in these particular situations. What about the primary bone sarcomas that present with fractures? Now it can happen in osteosarcoma, fracture can occur in Ewing sarcoma, and a fracture can happen in chondrosarcoma, which are the three most common primary bone sarcomas that come to us. Now for osteosarcomas and Ewing sarcomas, the treatment is reasonably easier. We can split them, cover them with appropriate neoadjuvant chemotherapy. And here you can see that the case of osteosarcoma has healed under the fracture has healed, that is, under the effect of neoadjuvant chemotherapy. And we can then go ahead, do a conventional limb salvage treatment and reconstruct them using appropriate reconstruction modality. In this case, a megaprosthetic reconstruction was used. Now, there could be some tricky situations, as I showed you a case of osteosarcoma earlier on, which was rotted, which was treated with nailing. This was a case that was picked up early, elderly gentleman. This was a chondrosarcoma, wherein the lesion extended right from the proximal femur to the distal femur. And this biopsy turned out to be a grade 2 chondrosarcoma, which was non-metastatic on the PET scan. And this can then be treated with, again, an entire femur resection and reconstruction using a total femur prosthesis. So yes, I mean, had this been sort of rotted or a nail had been put in this particular case, it would have been very tricky to contaminate the area, to cause higher risk of local recurrence in this particular patient, and eventually the patients may develop a lot of complications at a later date. So once these are approached carefully, these can be easily managed well, and at 4 years down the line, this patient is doing all right. We still need to keep him under follow-up. But more importantly, more commonly, the pathological fractures that will be presenting to us will be those cases who have a primary carcinoma somewhere else in the body and which has metastasized to the long bones. In these particular cases, the metastatic pathological fractures or impending pathological fractures, we have to remember that conservative management is reserved for a very select few type of patients, and most of the times operative management is required along with the other modalities of treatment like chemo, radiation or hormonal management. If it's an upper extremity, say a proximal humerus, and if it's a neoplastic etiology which is very well responsive to modalities like chemo and radiation, for example, a multiple myeloma which is going to respond very well to chemotherapy, these are the cases, or a prostatic carcinoma in the upper limb which is going to respond very well to hormonal treatment. These are the cases where we can attempt non-operative treatment. However, if it's a lower extremity lesion, and if it's an aggressive type of a lesion such as a thyroid primary or a renal primary, then it is always better to go ahead and do some sort of fixation before we start the treatment. We have to understand that pathological fractures behave very differently than our routine traumatic fractures. The bone is affected because of the disease, because of the chemo that the patient may have received, radiation that the patient may have received, and the biology is impaired. We cannot really depend on the biology for helping us in the healing in these particular cases. So we have to assume that the fracture is not going to heal and then use our fixation modality accordingly. The general principles are very straightforward, but it's important to understand them because as orthopedic surgeons, we are tuned to more of those AO principles of fixation where we rely a lot on the biology and the blood supply. So we have to remember that in metastatic pathological fractures, the operative intervention is usually palliative. In select cases like renal cell carcinoma or thyroid primaries, our surgery is going to improve the survival in the patient. We have to provide immediate stability, which gives an immediate pain control to the patient. It helps the patient to reduce the rehabilitation period and allow them an early mobilization. We have to aim for minimum morbidity, and we have to have an operative reconstruct which is reliable and durable, which has to last for the duration of the survival of the patient. We should not be letting the patient come back to the operation theatre again for the same fixation because he's got a limited lifespan when we are talking of metastatic fractures. We have to know for how long the patient is going to survive. So if we are planning an intramedullary fixation, we hope that the patient is going to survive for a minimum of 3 months. Otherwise, our operating intervention is of no use to that particular patient. And if you are going to do a wide resection and replacement with mega prosthesis, we expect that the patient should survive for at least 6 to 12 months. Because again, you don't want to do a very major surgery for a patient who's got a very limited survival span. So say for example, a patient with brain metastasis, you don't want to do a very aggressive sort of a treatment. And there are different scores that are used. The most common one that we resort to is the category scoring system. I won't go into the details, but just to give you an idea, basically what we consider is that what's the primary, how rapidly progressive the disease is, whether the patient has any other visceral organ metastasis such as in the brain or in the lungs or in the liver, and whether the patient is responsive to chemotherapy or radiotherapy or not. The disease is responsive or not. So these are the factors that we consider. A few points are given, and depending upon those particular scores of those patients, we decide what to do, to treat the patient with best supportive care or to go ahead and do a surgery for that particular patient. So how do we treat these particular cases? How do we decide what surgery is to be done? And when I'm going to talk about this, I'm going to talk, sort of restrict my talk to metastasis, impending pathological fracture or established pathological fracture in a long bone for this particular talk. So it's either impending or established pathological fracture. There is a role of prophylactic fixation definitely, because you don't want to let the patient go on to have an established pathological fracture and then come to you, because it's obviously very painful and the treatment becomes much more problematic after the patient has metastasis. So how do we decide? And there's something you might have heard of, a middle scoring system. It also predicts whether to do a prophylactic fixation or not. So again, this is a scoring system which takes into consideration the nature of the lesion, whether it is lytic, blastic or mixed, what's the location of the lesion, whether it's in the upper extremity, it is peritrochanteric, or whether it's in the lower.
Good afternoon, everybody. I'm Dr. Srinath Gupta. I would like to thank TOSACON, the organizers, Rakesh sir, Monzul, for giving us this opportunity to be here and then organize the ortho-onco session and also conduct the panel discussion. So, orthopedic oncology, the cases are very scarce, so we generally tend to make some mistakes here and there. So, the whole purpose of this panel is to try and make sure we manage them correctly before we refer it to a specialist center. So before I start off, I would like to say a few words about Yogesh sir. So if you can see the display picture that was earlier presented, that is completely contrast to what Yogesh sir is like right now. He's actually an inspiration for all of us. And this is how his usual weekends are. He's an avid trekker and he takes part in triathlons and also marathons. So that is Yogesh sir for you. So from here on, I would like to start about discussing my first case. So we have a 19-year-old male which came with pain in the right hip for 2 months. And the patient had no specific history of trauma. Dr. Harsha, how would you proceed further if such a patient presents to your OP?
The pain in the young male with pain for last 2 months. First of all, we have to exclude any general conditions, whether it could be any trauma or it is related to any infection or some synovitis type of thing. Or there are some classical symptoms like aggravation of the pain during night time, or any diurnal variations. We have to go detail into the history to find out the pathology, whether it could be like infective, traumatic, or some neoplastic etiology. Some more detail into the history.
Alright, history has no specific indications or nothing pointing towards anything. What next?
So after this, I will proceed for an examination, clinical examination of the patient, whether I can find any swellings around the hip joint, how is the knee range of motion, what is the attitude, what's the gait and everything. If I get with that information, then I will proceed with the basic radiograph of the hip joint, proper, AAP and that.
So rightly said, examination and history play the main crux of what you're going to do next. So this is an X-ray. Dr. Rajiv, if you can.
This is a plain radiograph, X-ray of pelvis with both hips.
And you can see that there is a lytic sclerotic lesion with ill-defined margins and a permeative appearance in the supraacetabular region above the hip joint. And there seems to be a break in the cortex, the lateral cortex, with some soft tissue shadow and soft tissue calcification also present. There is no clear periosteal reaction, and the medial cortex seems intact.
KNR sir, how would we proceed next if you see such a patient and an X-ray in your OP?
Further investigations like routine biochemical investigation. Apart from that, MRI of the.
So, like sir rightly said, first an X-ray and something suspicious. Next would be a contrast MRI. Himakan sir, if you can throw some light on the findings on this MRI.
You can see there is, apart from the lysis within the bone, you can also see a soft tissue component there.
So like sir rightly said, there is some soft tissue component as well in the supraacetabular. Yogesh sir, now we have a patient with a lesion in the supraacetabular region. What would we do next? Yogesh sir.
So I believe all the lab parameters are okay?
Yes.
Alright, any other investigation that you will like to get?
Nothing.
For staging investigation maybe? Or you get a staging investigation typically done after a biopsy. What is your school of thought?
Yeah. So biopsy first and then plan next.
Alright, yeah. So this is definitely a neoplastic lesion, or in a rare case scenario, we have to keep in mind that sometimes infections can also mimic the tumor. Typically in the central area, we can see that there is a cystic degeneration. So we know that there is a signal intensity change, there is a lesion in the supraacetabular area with cortical breach on the abductor side, soft tissue extension anteriorly and laterally. Before we do anything else, we'll have to have a biopsy diagnosis. So we prefer to do a genital biopsy in such scenario, and the location of the biopsy scar is going to be along the line of incision of the definitive procedure if you plan to do anything in the future, depending on the histopathology report. So in these cases, in periacetabular or supraacetabular neoplasms, the line of definitive surgical incision is going to be along the iliac crest, and then it's going to follow the inguinal ligament and going towards the pubic symphysis along the superior pubic ramus. So I would prefer a biopsy incision somewhere near the anterior inferior iliac spine and go down obliquely into the lesion to obtain adequate amount of material on genital biopsy. I'm happy doing this under CM guidance, but a CV guided genital biopsy can be done as well.
I would like, as you have given elaborated class on pathological fracture, do you advise any non-weight bearing at this stage for the patient because it is an established region with a lighter lesion?
Yes, yes. One of the advices in this particular cases is to remain non-weight bearing with walker till we advise on the further management.
Just for the sake of audience, I would like to highlight what you already said. Himakan sir, why should we place the biopsy scar in the line of the future incision?
Because always the biopsy scar has to be excised, the tract has to be excised. So, if you go eccentric away from the defined surgical plane, then you're going to resect a lot more. And now reconstruction also, function-wise and reconstruction is going to be very difficult.
So, like sir rightly said, we have to do a biopsy, and I would like to highlight few advantages and disadvantages of an open biopsy and a closed needle biopsy. Closed needle biopsy, the advantages are it's minimally invasive, less contamination, it's a local anesthesia procedure, and then can be done in OPD and economical. The disadvantages are the risk of negative results a bit higher, and also risk to neurovascular success because it's a blind procedure. Whereas an open biopsy, the advantages are you get more tissue, but the chances of putting in a larger incision, higher risk of contamination, and then it's a general anesthesia procedure, so admitting the patient, and also the risk of pathological fracture also very high. And like we rightly discussed, if it's a closed biopsy, the scar that will be excised post-procedure is very less compared to an open biopsy. And whenever you do an open biopsy, more often than not, patient will need to patient will need probably a plastic surgery flap along with the final reconstruction. So these are the things to avoid. You should not go in the intercompartmental planes. You should stay away from the major neurovascular structures, enter through the affected compartment, and also avoid calcified and necrotic areas. And there are few specific indications for an open biopsy. If you need more material to run molecular genetic analysis and the repeated close biopsies are not giving a representative diagnosis, or if the biopsy done is not correlating with the radiological diagnosis. And these are the things to avoid when you are doing an open biopsy. It has to be, it should not be a transverse incision. It should be in the line of the future surgical scar. Major neurovascular structure should be avoided. Never biopsy through the joint. And the drain exit site should be in line with the incision. Try not to raise flaps. Try not to give any wound washes or peroxide wash or anything. And if you suspect pathological fracture, make sure you immobilize the patient adequately. Now, these are the approaches for different lesions. If it's a proximal femur, it has to be lateral. Again, femur shaft, again lateral. Distal femur can be medial or lateral. If it's humerus, it's anterolateral through the deltoid. And if it's proximal tibia, again it's from the medial approach, and fibula, it's lateral. So that's an article which shows, explains beautifully the approaches for different sites. Now, this is what is required for a biopsy. Now, let's see what happened to this patient. So if you see the purple line there, that is the incision. The purple round there is the ASIS, and this is how the patient presented to us. Patient underwent an open biopsy scar. It's in the posterior aspect through the glutei, and the drain exit site is well away from the scar. So this is exactly something like, what not to do in orthopedics. So never do an open biopsy. Even if you do an open biopsy, try doing it in the same scar. When you are in doubt, try discussing with someone who might do the final surgical procedure. And, that would help in correct management. Now I would like to take one more case. This is a 4-year-old boy.
Sorry to disturb you. What was the histology on this?
That came out as Ewing, sir.
Ewing sarcoma.
How would you manage this, sir?
Yeah, so that's the point that we were trying to make. A primary bone sarcoma, high-grade sarcoma like Ewing's, open biopsy done through the abductor site, drain site contamination, surgical site contamination, and it's going to be a very big issue managing.
And this is the post-chemo MRI. If you see, it's not responded well to chemotherapy.
Right. So the management will depend upon whether he's metastatic or not metastatic. We would typically get a PET CT done to have a look at the staging.
He had a solitary sub-centimeter lung nodule, which is still the same.
Okay, so we will consider it non-metastatic for the moment. The treatment is going to be in the form of neoadjuvant chemotherapy, the induction chemo as we call it, ranging between 9 to 12 weeks. And we reassess, we see for the change. This is going to be the post-chemotherapy appearance. There are two modalities of treatment primarily in Ewing sarcoma. Either we think of definitive radiation, or we think of surgical excision of the tumor. We'll have to have a discussion with the patient and the family, and then take a call further. But during the surgical excision, we have to take out the entire abductor area through which the biopsy was done, and that's going to mean a lot of morbidity to the patient. So all of this will have to be discussed with the family.
So this discussion of definitive RT, sir, is this based on the open biopsy scar, or?
Yes, the open biopsy, the contamination caused because of it, everything has to be taken into consideration when we decide about the definitive local management of the tumor.
So, like sir rightly said, just because of the open biopsy scar, we are offering definitive radiotherapy for someone whom you might offer surgery and post-op RT. Right, sir?
Yeah, that was a major decision-making factor.
So, an open biopsy will make changes in the final decision. So, try not to do it, and it has to be in the line of the future surgical scar. With that, I would like to end my discussion. I will ask Dr. Himakant sir to take over with the next case.
You need to put up, yeah.
Yeah. Dr. Himakant, did my MBBS here, batch of 93 to 99. Thanks to the organizers, to Ram Kumar Reddy sir and so on for giving us a chance to present here. This is a lot of surgeries being done based on the MRI report. So mine is a very brief one. Imaging can be misleading or kind of don't be fooled by imaging. So this is a 40-year-old male present with shoulder pain of 1 year duration and insidious onset was progressive. The only comorbidities was diabetes and glaucoma. Remember, he's a 40-year-old, shoulder pain of 1 year duration. This was the X-ray on here. On the left is about a year, about March 2021. Presented to the orthopedician and he was treated with medication and so on. And the one on the farther end is the one taken in December 2021. So, Rajiv, you describe this?
An X-ray of the shoulder with the humerus. It shows a lytic lesion in the proximal humerus in the epimetaphyseal area with break in the lateral cortex and diffuse permeative appearance with no clear periosteal reaction.
Yeah, this appears. Can you go back to the X-ray? Yeah. Okay. So this is a 1 year. There's a 1 year difference between the two X-rays. The second X-ray on the right is showing a lytic lesion. There is a little bit of a cortical expansion on the lateral side at the rate of tuberosity. Maybe some soft tissue extension. The zone of transition, I would say, is reasonably narrow or well defined. Hardly any metrics, no appreciable periosteal reaction. 40 years old, I would tend to categorize this as a benign aggressive neoplasm of the proximal humerus, looking only at the X-rays.
Like sir said, benign aggressive lesion. So X-ray looks like GCT. Now I'll go ahead and curettage. Am I doing it right?
No, you need to investigate further. Serum parathermal levels has to be checked initially. MRI has to be done, biopsy has to be done. Then only we can come to that conclusion.
Okay.
And regarding the first radiograph also, if we see we can see mild lysis in the proximal.
Yes.
Yeah, if you see here, there is mild lysis along with the vertical striations clavicular.
I have had the advantage of seeing this a
Yes,
little
yes.
more often. But
The cortex has to be
reached
thinned out.
in the cortex.
Yeah. And MRI at that juncture also will help.
So I'm sorry I didn't have the soft copy. They came with the films. I take these copies. So these are the films.
Can you run through the imaging? Can you show us all the images?
Yeah. T2 and T1 before. I think I have a few axials as well. Yeah. Okay, now, I guess, or what do you think?
See, based on MR and radiograph, I go for first diagnosis at benign aggressive.
This is definitely aggressive. I mean, the X-ray and the MRI findings are not matching. The MRI is showing a much more aggressive tumor, a large soft tissue component around the proximal humerus, and the pattern is pretty destructive on the MRI. I would keep a diagnosis of either a very aggressive primary bone neoplasm in mind, or this could also turn out to be a hematolymphoid neoplasm. But the appearance on the X-ray and the appearance on the MRI is totally different.
You're thinking of an aggressive lesion, but the duration is 1 year.
Yes, yes, but the MRI appearance is pretty aggressive. Yeah.
Because of fracture, hematoma and all that.
This sort of a soft tissue component? No. No. You had shown us a T1 weighted image also, and that did show the that did show the extraosseous tumor component, which is not just a collection. It is a lesion. That cannot be just because of hematoma or fracture.
Again, coming to your class, sir, because you were mentioned regarding metastasis
Yes.
in an elderly male. He's a 40-year-old male patient with a lytic lesion in the proximal appendicular skeleton. Will you suspect metastasis?
Yes, for a 40 plus, yes, but that will be lower down on my differential years.
So, what next?
That's
No, not
why?
without any definitive operative procedure should not be. You should not go ahead without a biopsy diagnosis.
Tissue diagnosis is first, huh?
Yeah. Because what type of surgery you're going to do is all going to depend on your histopathological diagnosis.
So, they went ahead, did a core needle biopsy, and
Any sarcoma.
40-year-old.
CD99 positive.
CD99 positive. I basically brought this up because these images have come to me when I saw the patient, and in fact Srinath also had seen the same patient, and we had both of us, the first, as you said, the X-ray and the MR didn't match, and we were what your first provisional GCT, 40-year-old, this pain for 1 year, as Harsha said. So GCT, but obviously I would biopsy and then go. So that's why I said imaging could be misleading, and you can't go with what a radiologist has said. Many a time they don't have access to the history of the patient and maybe even the X-rays. So MR done elsewhere and so on. So that's why you need to be extremely careful. Get your biopsy. Be safe. It is safe for you and for the patient as well. The next one, Ravi.
Good evening, everybody. We would like to thank the Telangana Orthopedic Society for giving us this opportunity to present our cases at TOSACON 2022. I would like to present a couple of cases, the first of which is whether we can save the knee joint in a case of a distal femur tumor, or whether we should go ahead and do a prosthesis for a case that is looking like this, which we normally see in our OPD regularly.